Hello everyone, I'm Dr. Abraham from here, the dermatology specialist, and today we shall take a quick look at dyshidrotic eczema, oftentimes called pompholyx, and this is one of the conditions that one should be well versed with because it has a few differentials that can mimic it, as well as it's one of the hardest eczemas to manage. So as you can see in the pictures displayed on the screen, we see someone here having deep-seated vesicles and papules on the palms, as well as we see these scaly patches, well demarcated still on the palm. So it can present like that. They are in different individuals. So when we look at the dyshidrotic eczema, as I've mentioned earlier, it has been called different names. The first one being pompholyx, which simply means larger bully, and sometimes it's also called the acute and recurrent vesicular hand dermatitis. So the key features in this dermatosis or in this dermatitis is that someone will get firm pruritic vesicles on the palms and soles, as well as the lateral and medial aspects of the fingers and the toes. So that's why we'll be seeing these lesions mostly, and it has been associated with other eczematous conditions like atopic dermatitis, as well as a contact dermatitis, which can either be allergic or irritant. So there's no disturbance with sweat gland function, despite it being called dyshidrotic eczema. So when you can see this picture that I put here at the side, you see that these deep-seated vesicles, some of them coalescing to form a plaque, are located on the lateral margins of the finger, and sometimes they can be on the palms, like you can see around here, as well as this is another one there, another one there. So those are the deep-seated vesicles that we usually see in this condition called dyshidrotic eczema. Usually they're very, very pruritic. Then we define it as a chronic relapsing palmoplantar eczema characterized by firm pruritic vesicles and bully. So in the pathophysiology, vesicles are usually caused by spongiosis within the epidermis. You know, in spongiosis, you have accumulation of fluid between the cells or intercellular edema that gives you separation. So in this case, the fluid is too much that it ends up forming bully just below the skin or below the stratum corneum. Now, when it comes to the stratum corneum in the palms and soles, usually the stratum corneum is a little bit more thick than compared to the rest of the body. So that's why it will give you these deep-seated vesicles. Then we have to understand that it has been strongly associated with other eczemas, oftentimes atopic dermatitis or even allergic or irritant contact dermatitis, as I've mentioned. And when you look at it, it is not actually, it has no connection whatsoever with this function of the sweat glands, despite it being called dyshidrotic, because you know hyperhidrosis, what that is usually a relationship with sweat glands. So in this case, there's no relationship with the sweat glands, and this is just like a misnomer. So what you have to know is that we have factors that can exacerbate this dyshidrotic eczema, and this includes features like hyperhidrosis, exaggerated sweating in some patients, emotional stress, hot climates may be triggers, as well as sometimes rarely sunlight exposure can also cause flare-ups. So just like the other eczemas like atopic dermatitis, which is photoaggreviated, so even dyshidrotic eczema is also photoaggreviated. Then other contributing factors, we have atopy, we have allergic contact, and some patients, even in nickel and cobalt sensitivity, can also give you exacerbation of this condition. So in some of the cases, IV immunoglobulins can also be used to treat other things, but then clear up the cases of dyshidrotic eczema. So as we've mentioned earlier in the clinical features, we shall see symmetrical vesicles on palms and fingers, less often on the soles and toes, with vesicles ranging from pinhead size to several centimeters in diameter, which we call pompholyx, and those are just the large bully. Then they will be associated with pruritus. They can even become prurulent, where you have now pus, so they become pustules. And there's a condition called dyshidrosis lamellosa sicca. In this case, this is a variant that presents without blisters, but only with a few small scales or peelings from the palms and soles. So in the line of differentials, you have to think about things like tinea manum, tinea pedis, palmoplantar pustular psoriasis, as well as other things like dyshidrotic cutaneous T-cell lymphoma, Erythema malforme can also have a similar picture, fixed drug eruption, as well as infantile acropastulosis or acropastulosis of infancy. So all those will give you pustules, vesicles on the palms and soles. So you have to think about them every time you think about making a diagnosis of dyshidrotic eczema. So in terms of treatment, we usually use a strong or high potent corticosteroids, or sometimes you can even use systemic corticosteroids for a short time in case the condition is very severe, very pruritic, and then very bad. Then you can also give topical calcineurin inhibitors in some patients, but in case it fails, you can also do phototherapy or what we call light treatment with either UVA or UVB treatment. And you have to address the underlying contact dermatitis if it is present. In some cases, reacting to rubber accelerators, to rubber itself, or even preservatives, or even different materials, or the leather is in the shoes. So you need to also address the contact dermatitis if it is present, whether allergic or irritant. So in the pictures, this is how they will look like. You see these deep-seated papules. This is how it look like on the lower limbs. This is a close-up, and this is how the lesions look like in black skin on the sides of the fingers. So when you take off a biopsy, you'll find that you'll see a spongiosis with a well circumscribed macrovesicle and then thickened stratum corneum. Since this one you are dealing with the acro skin, I told you stratum corneum is a little bit thick, and usually we have also an extra added layer we call the stratum lucidum. As you can see here, if I magnify for you here, you see this first layer here is the stratum corneum, then this is stratum lucidum, then the granular layer down there, then you have this vesicle that is below here in the subcorneal vesicle that you see here with spongiosis though, and this is just water and a few blood cells and pus that you can see in there. So that's how histology will look like, and that's the picture we see on histology. So thank you very much. This was a short one on dyshidrotic eczema. Make sure you differentiate it from the tinea manum, the vesiculobolus type. You distinguish it from the pustular palmoplantar psoriasis. You distinguish it from dyshidrotic MF, that is a mycosis fungoides. You have to distinguish it from erythema multiforme, and so many other conditions that can give you pustules or even vesicles. Thank you very much. I'm Abraham from A&E Dermatology Specialist. See you in the next video.